This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
To your question about when these go into effect, that date is December 31st, 2026, but states are allowed to delay the implementation of these work requirements for up to 2 years. So that's through December 31st, 2028. They have to get approval from the Secretary of Health and Human Services, HHS, for that, and demonstrate a good faith effort to be working to come into compliance.
Hello and welcome to Sg2 Perspectives. I'm your host, Trevor DaRin. I have a large panel of guests with me today. Two folks from Vizient's advocacy team, Darren, Webb, and Alexandria Icenhower, who, with my colleague Ryota Terada, are going to walk through the latest act from Congress, OBBA. They'll talk about what that means and everything that's included in lots of depth. Know that there are plenty of other resources from both Sg2 and Vizient that go into more depth here, but we wanted to provide an overview through the podcast. Thanks everyone for joining. I know it's a dense topic. Alexandria, I'm going to go to you first on Medicaid eligibility. What are the new Medicaid community engagement and work requirements? How and when are these going to be implemented? What's the timeline? Give us some of the details, please.
Thank you, Trevor. I'll just dive right in. As our listeners are likely aware, the One Big Beautiful Bill Act, or what we're calling OBBB, made significant changes to Medicaid. Under this new law, states will be required to implement community engagement requirements, or more commonly discussed as work requirements, as a condition of their Medicaid eligibility. Specifically, this is for able-bodied working adults who are between the ages of 19 to 64. Enrollees would be required to report at least 80 hours of work or work-related activity per month. The look-back period for demonstrating that they're complying with this capped at 3 months. There are some exemptions that I wanted to highlight. These include parents and caregivers with dependent children age 13 and younger, pregnant and postpartum women, elderly, and individuals with disabilities. States are also allowed to define these short-term hardship exemptions, and then there's another short-term hardship written out in the law for people needing to travel for extended periods to seek their care. To your question about when these go into effect, that date is December 31st, 2026, but states are allowed to delay the implementation of these work requirements for up to 2 years. So that's through December 31st, 2028. They have to get approval from the Secretary of Health and Human Services, HHS, for that, and demonstrate a good faith effort to be working to come into compliance. One interesting thing I'll note, the final law also included text clarifying that states can actually implement these work requirements earlier than that date if they want. Somewhat it is up to the state.
Darren, on the financing side, talk about provider taxes and state-directed payments. How does that change?
Trevor, we really appreciate the opportunity to chat with you. In the case of some of the changing to Medicaid financing, have a tale of two kinds of states that's going on here. Because on one hand, you have one set of rules that applies to states that have expanded Medicaid underneath the Affordable Care Act, whereas on the other side, we have the states that have not. And they're each treated a little bit differently. The two provisions that you mentioned, particularly the provider tax piece as well as the state-directed payments, those account for about a third of the savings that came out of the health section of One Big Beautiful Bill. Provider taxes, the way that they're impacted is effectively everything freezes at this point. Whatever is currently in place right now, those levels are frozen where they are. What's going to happen moving forward, though, is that will continue to be the case for non-expansion states. So I believe it's about 10 states now who have not expanded Medicaid. But then for the other states that have expanded Medicaid underneath the ACA, what is going to happen is beginning in 2028, there is going to be a drawdown from the statutory top of the provider tax safe harbor, which is currently 6%, and that's going to be ratcheted down a half a point a year until 2032, when they'll be at the new maximum threshold, at least for expansion states, which is about 3.5%. So that is what's happening with the provider tax piece. When we get into state-directed payments, it's a similar thing where there's a grandfathering provision where what is in place now stays. However, ultimately, the top-line threshold for state-directed payments is going to go down. In the case of states that expanded Medicaid, it goes down to 100% of Medicare rates, or 110% when we are talking about non-expansion states. What is going to happen is beginning in 2028, that's kind of the key date here for a lot of these financing changes. And this is true for both expansion and non-expansion states. We're going to see state-directed payments reduced down by 10% a year until they hit those 100 and 110% thresholds, depending on if we're talking about an expansion state or a non-expansion state, respectively.
Thanks. That's great detail too. All right, Ryota, talk about implications around these Medicaid changes, how we're anticipating that's going to impact access to care for hospitals and health systems.
As we're thinking about our conversation we've been having with our members, a couple of topics rise to surface, thinking about the implications to uncompensated care and bad debt, certainly because of the implications that it may have to Medicaid coverage. As we're thinking about the Medicaid eligibility restrictions that Alexandria outlined, right? Thinking especially around community engagement and work requirements. But also, this might be compounded by things that are outside this law. Thinking about the expiration of the enhanced ACA subsidies that are scheduled for the end of this year. Disclaimer, we're talking about this on July 17th, so if anything's changed since the recording, forgive us. But that's projected to have millions come out of insurance coverage. As we're thinking about both those impacts, uncompensated care and bad debt growth is top of mind for our members. Meanwhile, thinking about the impact that this might have on our community, our patients, our beneficiaries, those same eligibility requirements may also lead to increase in Medicaid churn. This is where you have beneficiaries come on and off Medicaid within a period of a year. And we know that this leads to higher utilization of hospital services, emergency department, acute care services. When we can try to mitigate those impacts, maybe by addressing gaps in medication coverage, for example, when we see organizations such as Ascension Health partnering with Dispensary of Hope to provide free medication for patients that are uninsured, going forward, that's going to be critical as we're thinking about how do we manage or offset or mitigate the impacts that we may see in terms of preventable admissions or preventable usage of high acute care settings.
Well said, Ryota. And maybe others were concerned because there was a last-minute addition to this bill to try to buoy rural health systems. Alexandria, can you give us some of the details there around eligibility? What does the program look like? When does it begin? I know there's a lot of details and a lot that's up to the states.
So the law creates what's called the Rural Health Transformation Program. It's funded at $10 billion a year for fiscal years 2026 through 2023. So that's where the $50 billion comes from. And the intent of that is to aid rural residents and stabilize rural hospitals. To receive this funding, states must be the ones to submit a detailed rural health transformation plan. And the CMS administrator, to your point about timelines, will set the submission period for these plans. But it has to end by at least December 31st of this year, so 2025, which is the date when plans need to be approved or denied by the administrator. These plans that the states submit need to highlight things like how the states will improve healthcare access and outcomes for rural residents of the state, use new technologies for chronic disease, encourage strategic partnerships between rural hospitals and other providers, enhance clinician recruitment and training opportunities, prioritize data and technology to help furnish care, and then some other things like strategies to manage solvency for hospitals and identifying causes driving some of these hospital closures in rural areas. States also, as part of this plan submission, must certify that their funds won't be used for intergovernmental transfers or certain other public expenditures. The way sort of the funding is divided up, half of the available funds will be distributed evenly among all the approved states. The remaining funds will be allocated to states at the discretion of CMS. Determining that kind of discretion, CMS needs to consider population metrics, proportions of rural facilities, the situation of certain hospitals in the state, and then other factors that the CMS administrator can set. Now, this is where it gets even more interesting and probably more relevant to what our hospital providers are wondering. The law is very specific in prescribing a number of uses of the funds. So how states, being the ones receiving the funds, can then use the funds. States can't use more than 10% for administrative expenses. States have to choose at least 3 of the designated uses that were outlined in statute, or the CMS administrator can also add some other uses. Some of the ones outlined in statute that they can choose from are around chronic disease management, recruiting and retaining workforce, payments to healthcare providers for provisions of items and services, technology and tech-enabled solutions like robotics, AI, remote patient monitoring, and then also training and technical assistance on those types of solutions. There's also some stuff around innovative models of care and value-based care, improving efficiency in cybersecurity, access to mental health and substance abuse treatments, and then right-sizing delivery systems. It's even more detailed than that. I'm kind of just scratching the surface, but those are some of the main buckets in the text. It's really interesting to note the law outlines requirements and uses for states to get this funding, but not the process for providers or others to get the funds. That's likely going to be determined at a later point by the states, depending on kind of those uses that they choose. And more guidance probably also will be set by CMS on that. And also, interestingly, it's not limited to just rural hospitals. Other healthcare providers and also suppliers, tech partners, companies, others may also be eligible for the funding, just depending on how the states set those uses.
So, Darren, what do you see as opportunities, or what may the authors of this portion of the bill have seen as opportunities to improving rural care delivery through this program?
Yeah, I think that they see a lot of real opportunities here. And one of the ones that Ali mentioned a couple of times that I think is really worth looking at is talking about workforce and what we can do to recruit folks into more rural areas to help care for those folks. On top of that, you also see a real opportunity for major investments in technology and probably in some of the background infrastructure that you also need to carry that off, as well as talking about collaboration and partnership. Another thing to think about is who are your strategic partners if you're at a rural hospital, let's just say somewhere in the middle of Nebraska or Wyoming, where folks are pretty thin on the ground. Who is it that you're working with in other places, and how do you bolster and do more so that you can be working with, say, again, maybe we're talking into the Denver metro area, maybe we're talking about into Omaha or even Cheyenne or Casper. Again, when we're talking about, say, Wyoming or Nebraska, just to have somebody to pick on. I think something else, though, that I'm also very interested in seeing is exactly where the funding ends up going in terms of the somewhat more discretionary side, because there are some states that are much more rural than others. I went to Wyoming because that's a state of 500,000 to 600,000 people. That one of the jokes in Washington is the most overrepresented state in the union. What do they get in proportion to my home state of Delaware, which technically does not have a whole lot of rural to it? That's going to be another one of the questions here. And what do those opportunities end up looking like as we begin to see what the implementation side of this looks like?
Really good. Darren, I'm going to come back to you because Ryota mentioned the ACA before. What changes were made that impact the ACA marketplace, and give us the timeline of implementation?
Sure. So I think the way I'm going to talk about this when I get into specifics is going to be according to the timeline, just because there are a variety of key dates where things are happening. But to put it into a tight little nutshell, a lot of the real changes we see, which can have an impact on health providers, relate to some eligibility requirements around the advanced premium tax credits for ACA plans. And the key dates for that are what I'm going to call plan years 2026, 2027, and then 2028. In 2026, we're going to see three different changes. The first one is there's going to be a block on folks who are not able to qualify for Medicaid because of their immigration status. So they will no longer be able to access the premium tax credits based on that. Additionally, we're going to see some tightening of some of the special enrollment period rules. And we're also going to see full recapture of whatever overages may be paid in terms of the tax credits currently. That is actually held down and capped based on income. Now, then when we move on to 2027, we're going to see a narrowing of exactly what immigrant populations qualify for the subsidies. And finally, in 2028, we are going to see an enhancement in terms of the verification of eligibility requirements related to the premium tax credits. And it's going to have a significant impact. To give you an idea, just from a dollars and cents point of view, CBO figures that's around $213 billion over the course of 10 years. A significant amount of money and a significant impact. And overall, all these different provisions I will mention, CBO estimates based on an earlier version of the bill and not the final version, we're still waiting on a score there, is the coverage impact should be about 11.8 million Americans ultimately, is what we believe the impact will be in terms of coverage losses.
Okay, thanks for covering the pieces that are in the act so far. Now talk beyond OBBA, and I'll send this to both of you. You can pick and choose. We had like Medicare telehealth, hospital at home, ACA subsidies, site neutrality on the radar as things that may have been included here, but weren't. What's on your radar the rest of the year? Which of those are members talking about as maybe priorities? Give us the remaining stuff landscape.
That's right, Trevor. There were a lot of things that we've been watching not addressed in the OBBB that Congress both will have to address in certain cases or will want to address this year. One of the main things coming up that we're watching is appropriations. Back in March, Congress passed a continuing resolution that extended congressional spending through September 30th. Congress is going to need to pass something for them to avoid a government shutdown after that date. Some of the provisions, probably most of interest to healthcare providers that need to be addressed by then, are the telehealth flexibilities, hospital at home, certain pandemic preparedness provisions, relief from the Medicaid dish cuts, some of the things around teaching health centers, GME funding, Medicare rural extenders, among others. But the timeline is extremely tight, depending on the chamber, some potential schedule changes we might see here soon. They have somewhere between only 15 to 25 legislative days to address this, and Republicans will need Democrats to clear some of the procedural hurdles past this, and it's unclear right now if Democrats are going to want to help Republicans get this done after the OBBB. There's a rescissions package that today they're voting on, so could see a shutdown come October. It's definitely something we're watching. But I'll turn it to Darren if he wants to talk more about other things we're watching outside of that and potential for more reconciliation.
Oh, you just had to go there, didn't you, Allie? Where we see things going at this stage is we have an expectation that all the things that Allie said are absolutely in the mix. And that's what Congress is paying attention to now. What are the things that absolutely have to be done by the time that we hit September 30th? And for that matter, usually the way that this ends up working is Congress will end up punting a lot of these questions out towards the end of the year. So probably more into a December timeframe is when a lot of longer term decisions will be made, and the shorter term decisions, we're talking about kicking the can down the road. Now, another piece of this to keep in mind, and to Allie's point about how Dems are feeling, when we're doing a reconciliation process in this day and age, whether it be a Republican reconciliation process or a Democratic reconciliation process, that strongly tends to be an internal political family conversation. And the opposite party, who are not really a part of those conversations, a lot of bad blood is created. We've been seeing that happen time and again when Republicans have had the opportunity and when Democrats have had the opportunity. And that's one of the questions right now is what's going to happen. And if folks have been tracking the news and everything, you may have heard that Republican leadership has an interest in possibly doing more reconciliation processes, possibly 2 additional bills. Now, exactly what's going to be in there, exactly what the timing looks like, all of those things, I'm just going to say all good questions right now. And that is something that we are tracking closely and monitoring closely. But for right now, that is where we find ourselves, that there's a lot of questions out there about, is there going to be a shutdown? Can some kind of a deal be reached? And something else that I'm not sure that we really addressed that could potentially be of interest are the advanced premium tax credits. Those were enhanced back during the COVID period, and there is some talk of that possibly being a bargaining chip that could be on the table. We'll see what happens. That certainly is something that Democrats are very interested in. It's something that Republicans are a little bit more resistant to, but we'll see where that actually falls. But that is another major thing that we need to keep an eye on as we move towards the end of this year.
Thank you both. Ryota, if it's possible, put a strategic implications bow on this. How are hospitals and health systems adjusting existing plans, thinking differently about future growth plans to prepare for the impact and navigate? We heard how much is still on the table. I haven't gotten the sense from providers that they feel like, okay, the policy landscape is now stable. It still feels like just as much uncertainty.
Yeah, Trevor, I feel for our members' provider systems. They've felt like they've been weathering countless periods of uncertainty. This is the latest one where it's given a lot of our members we talk to the reason to go reassess the assumptions they've made as they're thinking about the strategic plans they have in place today. For those that have been listening to us, we've been a big proponent of deploying scenario planning, specifically thinking about environmental scenario planning, where instead of looking at different scenarios and having different options and pivoting each time, how do you still make big decisions that require long-term investments? That's when we're thinking about, let's look across these scenarios. Let's look across for each one. What would be the ideal reaction strategy that you deploy? And as you look across these scenarios and choices that you'd make, what are the commonalities, right? What are the common bets that you'd make? And one of those that comes to mind across most organizations at this point, margin defense, margin management, however you want to call it, thinking about what you can do to address the cost side of the equation, but also if your market has the ability, thinking about from your payer side, are there payer strategies, whether it's value-based care or others, that are opportunities to shore that up, to thinking about that greater trend or shifts that we see in industry where it's ambulatory first, ambulatory shuffle, however you want to call it. How does this play in where we're thinking about if we're going to be challenged to continue to serve the needs of our communities despite uncertainty for the reimbursement side or downward pressure on that, does the shift to ambulatory give us an opportunity to make that math work a little bit easier? Or do we need to go further than that? Do we need to think about delivering care that doesn't require any physical assets? Do we need to accelerate those transitions? Do we need to think about the workforce implications that are coming out of OBBB or other actions that maybe AI can help, whether it's automation to free up labor or to maximize what their impact is? All of those require long-term investments. And that's where we advise our members thinking about, yes, it's important to react and take the time to reassess each time something like this passes that's so big. But the approach should be one that allows your organization to be confident enough to still make big bets that enable that long-term transformation.
Well, thank you all. I know this will be a really helpful overview for our members, and I appreciate you putting so much time and energy into prepping to make it concise and share so much detail. So thanks for sharing your perspective as always.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at Sg2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, Sg2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You could find them at Vizient /podcasts. Have a great day.